And thank you for being patient because I needed a week off. So I took last week off and had a holiday with my family. God bless them all. It was a great trip and nice time to be away. Good weather too. So amazing time for everybody. And I managed to do a lot of surfing, which was kind of fun. We are back to work now and back to Fertility Fact or Fiction, and I have nowhere to go for the next several months, so you're stuck with me again. We have a great individual on the show with us tonight, a fertility coach and concierge that offers really specialized fertility services in Ontario, and particularly in and around London and Windsor and Chatham and Kitchener-Waterloo area. So we're going to be talking to Melissa McNichols, who's got an amazing program up and running and has chatted with us about her various options and things that she can do with us and how she can enhance the experience for patients. And then, of course, we'll do our normal question and answer segments and go through your questions and answer them live. So I'd like to welcome Mel onto the show. Hi, Mel. How are you?
Hi, I'm wonderful. Thanks. How are you?
Good, good. Thank you for joining us tonight. Exciting to have you here finally. And I have to apologize. We've kept Mel waiting for some time, but we finally managed to coordinate tonight. So I'm really thrilled to have you on the show. So tell us a little bit about yourselves, just so we can introduce you to everyone, and tell us about kind of how you got into this and what you do now.
Yes, so I think the biggest piece of this is that I am a former fertility patient myself for about a decade or so, and have, kind of been through a little bit of everything, IVFs and poor responder and low ovarian reserve, and some IVFs that didn't work out so well. I am lucky enough, I have a 6-year-old from an egg donor IVF cycle.
Amazing.
And I was diagnosed with endometriosis. We looked into private adoption, international adoption, foster to adopt program through CAS. So I've learned a lot over the years. And right from the beginning, the biggest thing that I noticed was how much information there is about infertility, because it's not just a one and done diagnosis and here's the fix and you can carry on from there.
Right.
And I didn't really know how to advocate for myself. I didn't know what questions to ask. I didn't know what options were available. I just didn't know any of that stuff. And you guys are amazing. You're doctors at what you do. You make babies every day, which is incredible. But I really found it was tough going to these appointments that I would wait weeks for. I would go, I was feeling overwhelmed and stressed out. I'd leave my appointment and I wouldn't remember what was talked about. I'd get on the phone and call my partner and he would ask questions about what was discussed and I'd say, I don't really know.
Right.
So it was very overwhelming. And so almost 6 years ago now, I started doing what I do now. I'm certified to provide injection training, subcutaneous and intramuscular injections. So I help with patients who are doing IVF and other medicated cycles. I can do that virtually and in home as well.
Okay.
I provide a lot of after hours care when the clinics are closed. I'm kind of your girl for that, to send me a text message or, we can set up a quick phone call at any time. But that's basically who I am and what I'm doing and why I'm doing it. And the other side of this is I am a certified doula as well. I love being able to follow through with these patients who have finally had, this pregnancy and are going to experience the miracle of birth. So I also offer childbirth education classes, doula support, postpartum care, breastfeeding support. Oh my gosh, the list goes on.
Yeah, I love that part of what I do as well, because I still deliver a lot of the babies that we create, especially the ones that are, relatively local to us. And it's fun. It's nice to be there from the A to Z. So I can completely appreciate where you're coming from on that. It's an amazing part of the experience for sure. And it's rare. the
Yeah,
vast
preconception
majority.
to parenthood is really the ideal.
Yeah.
I mean, sometimes you have an OB who's not on call, at the time that you're delivering, and now you have somebody else that you're with that maybe you've never met before. It's nice to be able to have the consistent care and support from somebody that that you've worked with for quite some time, built a really personal, close connection with, and I just love doing it.
Yeah, and I love the fact that your own personal history, and thank you for being so brave and sharing that with everyone, is really like you ran the gamut, right, from A to Z of everything in infertility. So it does really give you a really well-grounded experience and history, and it's really amazing to note that even for someone that had so many different things go on, you still found it overwhelming, having gone through all that and then getting through to the fertility part of things. So I think it highlights for the docs and the nurses and the people involved in, the front line of this, talking to patients, how important it is to make sure that patients do understand and they do feel comfortable. And I'm totally buying into this, fertility coach idea more and more now, because no matter how good a job I do, it's, you always hear, like, people hear the word cancer and then they don't hear anything else that the doctor says. And more I'm realizing that people hear various diagnostic terms in infertility, and whether it's low ovarian reserve or endometriosis or poor sperm quality, it's kind of the same thing. You say that and then they've not heard or can't process anything you say afterwards. And having that, assistant or coach or kind of partner through the process, it can be really, really kind of helpful for those patients. So, normally when you're engaging in a patient journey, where do you start, and how do they, how do you follow through with them, aside from what you mentioned already? Kind of walk us through what it would be like if my wife and I contacted you and said, hey, we're overwhelmed. What would you be doing with us and for us?
So, oh my gosh, when do you contact me? Anytime, really. And again, that's because I'm preconception to parenthood. So, sorry, I thought you were talking and I couldn't hear you, but it seems we're good. So sorry, you can contact me really anytime. I focus a lot on individualized care. I do not sell packages or, weeks worth of committed time for people.
Sure.
I do, the individual phone calls, video chats. A big part of my business, especially through COVID and the restrictions and the limited foot traffic into clinics, I've been attending a lot of people virtually at their appointments with their doctor. So even though they only have a limited amount of time in the appointment, I'm there as an extra set of ears. I take all of the notes. I will help to prompt questions. I make sure that all of their questions get asked. I then even send them a copy of the notes that were discussed, so that themselves or them and their partner have record of everything that was discussed from that appointment.
That's
and then
awesome.
we'll go over it together, because my goal is really what I didn't have when I had started my journey, was feeling really comfortable, confident, and educated about everything that's been discussed, so that, if this is your one shot at doing this, that you have very few what ifs. What if I had have known about acupuncture? What if I had have known about, CoQ10 or, different vitamins and supplements and, all of these different kinds of things. So that's really my goal. And that kind of focuses on the infertility stuff. And then again, it carries through into pregnancy and parenthood.
And you mentioned that you don't really have packages or weeks. So just so everybody watching knows, how do you bill your patients, or what kind of service arrangement do you provide them with?
Yeah, so I'm available, like you, essentially 7 days a week. I don't really get any time off.
Right.
And again, I focus on evenings and weekends after they're done, their regular work day. You can simply message me, whether it's Facebook, Instagram, through my website. My phone number is all over my car, my fertility mobile, I call it. So you can just reach out for a message. We'll find a time that's convenient for you, and my schedule and calendar to get a call set up for you. A telephone consultation is $45 for 30 minutes of consultation, either phone or video. The injection training, a lot of it I've been doing virtually, especially,
Sure.
COVID days. And location, of course, I know that my name is London Fertility Concierge, but really it's so much more than that. I'm actually working with another couple right now, all the way in Nigeria, which is incredible.
Wow.
But yeah, so injection training, if we're doing it virtually, it's an hour-long session. We go over all of your medications. If it's virtual, like I do have all of my injection training stuff here with me. We go over it all, make sure that you feel those things comfortable, confident, and educated about your injections, how you're going to feel, expectations, what your retrieval is going to look and feel like, that kind of embryo time there through to day 5, day 6, talk about PGS or PGT testing, your recovery, the 2-week wait, like all of these kinds of things in that 1 hour on top of your injection training. And it's the
Wow.
exact same thing if we're doing it in person. I will come to your home. It's $125 in person, unless if you're out of kind of the general vicinity of London and the immediate surrounding area, then it's charged a kilometer fee as well.
Sure.
But yeah, and then doula support is separate from that.
Cool. Do you find, and I'm just curious on this, that this is something that the fertility centers or fertility physicians in other centers are open to, or are they kind of more reluctant when they see that there's another individual, not necessarily the direct couple, on the call with them or virtually linked in? What's
They've
the
been very
response been
supportive.
like?
They've been very, very supportive.
Oh, that's
Like
great.
you and your clinic, you want your patients to feel informed.
Yeah.
You want them to feel really comfortable with everything that's being discussed. And the more information, the better. And like I said, as good as you guys are, there's just not the time to be able to commit to patients, to give them the real breakdown of the information that they're looking for. And it's so easy with somebody like me who can provide, something as simple as a 30-minute consultation, or we can do an hour if you want. But everybody's been really receptive. Most doctors and local clinics know me pretty well. I show up on FaceTime and I say hi to them. They say hi Melissa, and then them and the patient carry on.
Amazing. What kind of message would you give patients who are watching right now to, direct them in the best sort of path forward, on their journey, and how you can best kind of facilitate that process for them?
It's definitely about support and information. Yeah, you want as much information as you can have, as much knowledge is power. So as much of that as you can have to take forward with you, again, to try to limit the number of what ifs at the end of your journey, or the midpoint of your journey, that you really are aware of what resources are available to you. I always say, it sounds so cheesy that, it takes a family to raise a baby. And then I say it takes a family to make one too.
Yeah.
I'm a huge advocate for building a team of people along with your fertility specialist. Have somebody like me working with you, whether you're seeing a naturopath or an acupuncturist or a dietitian, or there's all kinds of other fertility related local specialists that are really, their goal is they want a baby for you too.
Yeah. Yeah, I love that. I think that makes a lot of sense. And you're right, support and information is huge. And we're good at providing support. And I'd actually like to venture out there and say that VRC is particularly good at providing support. But, no matter how much I explain things, like I said, once you say certain keywords, patients sometimes just can't hear the rest of it. So it is great to have that backup system in place for those questions that don't get answered, or where the processing just kind of ends and patients aren't absorbing any more of what I say. So I love the fact that you guys are out there and available, and obviously you're doing amazing work. So we're really pleased to have you on board. So we are in the process of adding a web page to our website, where we will kind of host a few of you select fertility coaches who want to work with us, and obviously you'll be on there as well. So I want to thank you for joining us. We're certainly happy to take questions from individuals, and if you want to hang out with us for a sec, there may be questions for you as well.
Sure.
So let me see if Tarek has any questions. He's kind of off camera, but he'll read them out and you'll hear them. He's the mystery man. Everybody's been asking what he looks like. We're going to turn him into like one of those mystery figures, bring him out in like a dark helmet, and that way no one will ever know what he really looks like. Yeah.
First comment was, Melissa, you are amazing. And the support you offer personally and through group support is awesome. So that's
great.
the first comment we got over
Well,
here.
thank you.
Thank you.
Yeah.
Second question, I believe, is, hi, Melissa. I have so many questions. What courses have you taken to become a fertility coach? Are you registered or have a governing body? Would you help someone interested in becoming a fertility coach start their journey?
Good question. So I do actually, like, I have a lot of nurses and stuff that contact me all the time asking if I need help with injection support and those kinds of things. Like I said, I am certified and insured to do the injections, and certified doula as well, for over 5 years now. Governing body in regards to doulas, I mean, there just isn't one. It doesn't exist. I have not yet considered kind of bringing anyone under the wing to help train other fertility coaches. That's a new thought for me. I think that answers all of the questions that were there.
Yep. Then I got one on Instagram for you. Melissa, personal knowledge is a godsend to people who are trying to have a baby. Thank you, Melissa.
Thank you.
Mel, you've got great reviews. That's amazing. Good for you. Well done. Those are the kinds of people we love working with, which is why we brought you on the show. So that's incredible.
I've been working really hard in the community for many years now. And I mean, it's been hundreds and hundreds of individuals and couples that I've helped support. I mean, I've talked to you about it, doing the fertility night that I host every month. I have a couple of Facebook groups for fertility, a donor conception group, pregnancy through infertility. Annually, I do a infertility awareness calendar, which are on the wall behind me. There's a couple of them there. Every October for Pregnancy and Infant Loss Awareness Day, we host a candle lighting. So I've really been out in the community for many, many years now. So I'm really grateful and thankful to hear some more great reviews. Thank you.
Anything else? Nope. Well, thank you so much for joining us. We really appreciate it. We will have you up on the website shortly, hopefully by week's end or next week for sure. And if anyone out there is watching, has more questions for Mel, you can either reach her directly or you can get her through us. So just contact us and we will be happy to put you in touch. And we will definitely support you as we move forward. So any patients of ours that feel like they need that extra level of support, we will be happy to connect you with Mel and let us know. And we'll go from there. So thanks again for joining us. We really appreciate having you on the show.
Thanks for having me.
Yeah, and we'll look forward to many good positive outcome stories together in the near future.
I'm looking forward to it. Thank you.
All right, have a great night. Take care.
You too.
Bye. So thank you for joining us. Wonderful to have Mel on the show. Obviously, lots of rave reviews out there about her. So really excited to work with her. And we're going to start integrating these fertility coaches into the work that we do, because it does kind of take that extra level of care sometimes. And it is really important to note that there are so many moving pieces to an infertility journey. And sometimes you do kind of get lost in the shuffle. And you lose focus sometimes as patients. I say you've got diminished ovarian reserve and everything just kind of gets shut down. So it's nice to have someone there who can tell you after the discussion that I didn't say it was all doom and gloom, but rather I said, hey, we can try this or we can try that. And that's really important because a lot of people leave a discussion hearing just one component and don't leave it understanding that what we were really trying to say is there is hope and there are options. And I always provide those to my patients. So I think it's really important that that reinforcement be there as well. So we're going to go to the question and answer period. I'm assuming you've got other questions coming out the yin yang now. So we're going to probably run till about 9:15 like usual. And then we'll get everybody ready for next week's show. I do want to preempt next week's show, and I'll put out an ad soon. There is a very exciting study that is in pre-publication right now, comparing 3 different routes of progesterone administration, as well as whether or not the levels of progesterone made a difference. I'm super, super excited because it confirms that everything we've been doing is correct all along. And so I will be bringing that to you guys next week. So don't miss that show. Hugely important, especially if you're in Europe and you're watching. Make sure you watch that show with us. We may even modify the time if we can manage it to account for the European folks and the North American folks, because it is critical to find out which direction or which administration route progesterone should go and whether or not the levels are important. So I am very keen to bring that one out to you. It's from Fertility and Sterility, and we'll share it with you next week. In the meantime, fire away with the questions.
Do several IVF cycles cause cancer? Do you think there should be a limit to how many IVF cycles we should do? If so, what do you think that cycle limit should be? Thank you.
So this is being studied, and we've actually presented it on the show. It was a few months back. There was a cancer and IVF article that we reviewed. So IVF does not cause cancer. It doesn't matter how many times you do it. It's safe from a cancer perspective. Infertility has been positively associated with cancer outcomes in women. In fact, even if the infertility factor is male factor, the women have a higher risk of cancer. Now, whether that has to do with the protective effect of pregnancy against many different types of cancer, or the added stress of infertility causing whatever it causes, we don't know. But the reality is there is an association between being infertile and having various types of gynecologic malignancies. Breast, ovary, uterus, they're all increased. But the treatments don't increase your risk of cancer. Now, the other part of this is, do I think there should be an upper limit to the number of IVF cycles? I actually do. I think that if you've tried IVF 3 times and it's not working, that you really need to sit down and question what you're getting out of doing it more. There is an older study out of Harvard that is frequently cited in the US, of course, where they demonstrated that if you did up to 6 cycles of IVF, you could get up to about an 83% pregnancy rate in those patients. And that included kind of everybody. They weren't picking and choosing. They were even including women who are much older, poor responders, so on and so forth. It sounds great. And it's probably not completely irrational in the US if you have insurance. But in Canada, where you're paying for it, or at least paying after your first cycle, it would be maniacal to do 6 cycles of IVF. Now, do people do it? Yes. Have I had people do 6 cycles? Once, only because she was only doing natural cycle, and so we were agreeable to doing it multiple times. But does it make sense overall to try that? No. I mean, realistically, there's a financial burden, there's an emotional burden. There's the risks of sticking a needle and all the anesthesia and all that stuff. So, will I do it? Very reluctantly. I would have to have very good reason to push someone that far. I don't believe in doing IVF over and over again, because at some point it turns into my just running a business and not providing you with medicine, and I refuse to do that. So I'm all about the medicine and providing you with good care. And, the business part of it is secondary to what we're really trying to achieve here. A lot of places don't work that way. And in particular, unfortunately, in the US, it's very business driven, but we don't have that model here. And for me, I don't care what I make. I'm very happy with what I have. I want to do well by doing right for the patients. So there is an upper limit to what's reasonable. And once we hit that limit, I need to have a long discussion with you about what's beneficial for you moving forwards.
Dr. V, you mentioned you have a clinic in the GTA. What is it called? Do you have a website where I can find more info? Thanks.
Yeah, so I don't have a clinic there. We work with various clinics there. I work with Create, and I work with IVF Canada. I have some friends at some other clinics, including Tripod Fertility. So there are a variety of clinics we have access to and that we can see patients through. But we do everything virtually now. If you want to meet with me in person, I can always make the trip out there. That's not a problem. and I can see you at any one of the offices or locations. You just have to tell me that's what you want, but just reach out to info@drvictory.com. That's drvictory.com. And then just say, I'd like a consult. And if you're in Canada, you're in the GTA, just have your family doc send a referral to us. And then we will get it up and running and communicate either virtually or in person anywhere you want. We've got patients coming to us from all over the world. So borders no longer mean anything. Location really doesn't mean anything. We can get you monitored anywhere successfully and carefully, and we can provide you treatment in multiple different locations.
How many days after an LH surge do you transfer 60 embryo for a natural FET with no trigger?
So that would be either day 7 or day 8. Because it's usually LH plus 7, but if you have a day 6 embryo, you could arguably go an extra day. Having said that, there are no studies that I'm aware of that have tried that, so most people would go LH plus 7.
Hi, Dr. V. I'm 31 and had 3 chemical pregnancies and 7 cycles. Progesterone levels have been normal. What could be causing this?
So that's a long discussion. That's a recurrent implantation failure or recurrent pregnancy loss situation in your case. So there's all sorts of possibilities. Your immune system, the sperm quality, the sperm DNA fragmentation, egg quality, social habits, smoking, drinking, drug use. Weight can be a big issue. Body mass index, your dietary habits, your vitamin intake, genetics, inflammation, infection, endometriosis, shape of your uterus, thrombophilia, and then now there's this whole vaginal microbiome, uterine microbiome, which is also really important. So there's a whole host of different possibilities. You need a very thorough workup, and I would get that before investing any more time or money into more cycles without knowing what's going wrong.
We are doing a natural cycle FET. You have mentioned you try to minimize adding estrogen. What determines whether you will or will not add estrogen after the transfer?
So we would never add estrogen after the transfer. We would only add estrogen prior to the transfer. But as far as the actual protocol is concerned, we would only add estrogen if your lining is too thin. If your lining is the right thickness, we don't touch it. We leave it alone, and you don't need any extra estrogen. So we do use letrozole because there's good studies that support the use of letrozole, and Lord knows our success rates are so high right now. I'm thrilled to bits about it because it's crazy how well we're doing. So we use letrozole as part of our protocol, and our protocol works. So you don't need extra estrogen the majority of the time when you're using letrozole. There are some women that do, in particular older women, menopausal women, because the letrozole isn't going to have the same impact. If anything, it may even make it thinner, but we try, and then we add in estrogen if we have to. Excuse me.
How long should you wait post DNC to try to conceive? Should you wait until after the first period?
No.
Can you ovulate with HCG in system?
You won't likely ovulate with HCG in your system, but by the time you have your next cycle, you can start trying again. Between the DNC and your first period, while it's possible to ovulate, it's unlikely. But after that period, you can definitely start trying. And there is a study out there that demonstrated that there is no difference. There's no need to wait multiple cycles. Years and years ago, we used to think, for no good reason whatsoever, that you should wait several months, but that's actually not the case. You can just start trying right away.
Can taking melatonin 5 milligrams every night affect an FET schedule for October? I have started taking them as of this month. Thank you, Dr. Victor.
Melatonin is another element that we use. We actually learned about it doing the show. So no, it's beneficial. We only use 3 milligrams, but I don't think there's a difference between 3 and 5. And it won't negatively affect it. It'll positively affect it. So it shouldn't impact anything for October. At least not negatively. It'll impact it positively, but not negatively.
Hi, Dr. V. We did this one. What Is the AMH AFC cutoff that indicates PCOS?
So AMH and AFC are not part of the criteria that we use to diagnose PCOS. PCOS is a clinical diagnosis made up of having women that have signs of hyperandrogenism, meaning acne, hair growth, weight gain, oily skin, hair loss on your head, and then things like irregular periods. You may have a high antral follicle count. You may have a high AMH. You might have issues with your LH and FSH ratios being off, things like that. So depending on which criteria you use, and no one fully agrees on what the criteria are, it's a clinical diagnosis. So it's the presence of signs of hyperandrogenism and then biochemical signs of it as well. Having said that, most of the time, if your AMH is over 25 picomoles per liter, you probably are going to tend more towards PCOS. Doesn't mean it's diagnostic by any means. And if you have more than like 20 follicles on each ovary, again, you're probably looking more at a PCOS situation. But those are not diagnostic criteria, and no one has proposed that they should be yet.
Had my first FET July 31st and had a negative pregnancy test yesterday and today.
Oh, I'm so sorry.
Beta is Thursday. Do I have a chance of still working? If not, where do I go from here? I'm having trouble coping.
Well, I'm sorry you're having trouble coping. Certainly, if you're one of our patients, you reach out to us, and we have all sorts of coping mechanisms in place. We have a huge support network and all sorts of things we can do for you. So we have our online program, we have our social worker, our psychologist, our amazing nursing team, me. So we have lots of people that can reach out to you and help you out. Could it still be positive? Yes. If you just had it on the 31st and we're 9 days out, so day 10, I mean, it's iffy. You probably should have a positive beta by now. But sometimes it gets missed. And so we never call it quits till we've done the day 14 or day 16 beta. So I would wait. Certainly if you're just using a home preg test, those are not reliable enough. And I strongly discourage people from doing that. So what techniques can you use to survive the 2-week wait? We get asked this all the time. You really need to reach out to your clinic. It's just reassurance. There is no technique. I mean, I can tell you to go do yoga and meditate and pray and all these things, but it's individualized, right? So whatever works for you is great. I wouldn't go on an ice cream and chocolate eating binge, but anything else, that works for you, that helps calm you and relax you and focus you is good. We've got all sorts of stress reduction techniques in people here. So we use our team.
We have no known clotting factors, but have decided to add Levinox after several failed transfers. Should it be started day of transfer or earlier?
No, started earlier, a couple days earlier, because you want it to be in your system doing what it's supposed to do before the embryo arrives there.
Hi, Dr. Victory. I am doing my egg retrieval this month. Okay. I have lost over 50 pounds to get my BMI under 40.
Amazing. Congratulations.
I have been doing 30 minutes of fasted cardio in the morning, then T25 and P90X3, then 30 more minutes of cardio in the afternoon.
Oh my God. Wow. Okay, I got to come work out with you because I need to lose a few myself now.
What should I be doing for exercise during this time, or should I continue with my routine?
Don't continue with that routine once you start your stim, because you're going to be drawing blood flow away from your ovaries, number one, and number two, if your ovaries get big enough, you're going to tort them. So don't do that. You can continue with cardio as long as it's not plyometric. So no jumping up and down. Elliptical, tread climber, stair stepper, something like that would be fine, but not hours and hours and hours of it. I mean, keep it reasonable for yourself. And your achievements incredible. So from all of us, and hopefully everybody that's watching, lots of hearts and thumbs ups and all the stuff that you can sprinkle on the social media stuff. That's absolutely phenomenal. It is patients like you that really inspire me to continue doing what I do, because it tells me that when I tell someone we need to get you healthy to move forward, there are people out there that actually listen. And I love that, because there are honestly a lot that don't. And so I cannot thank you and applaud you enough for doing what you've done. That's absolutely phenomenal. And you are the standard bearer and the example for all the rest of us to live up to. I now feel like I need to go lose a ton of weight, because I got on a scale today to check our scales and realized I gained a ton of weight. So holiday was a little too good. My kids were all making fun of me, and I'm now going to be inspired by you and go do Focus T25 again. I'm on it. I got it.
That's great. First beta, 10 DP 5 DT.
Yeah.
Equals 18. 3 days later, 60. 3 days later, 279. 5 days later, 1529.
Okay.
I know these numbers are low, but multiplying accordingly.
No, those aren't low.
On hope moving forward, no cramping or bleeding.
Those aren't low. Those are pretty normal. I mean, I don't know why they did them in 3-day intervals. It should be 2-day intervals, but you need a 60% rise every 48 hours minimum. Having said that, when it's very, very early, like day 10, it doesn't rise in the same doubling or 60% rise. So that's a little bit later, but your numbers sound reasonable. So I would just hold off. And by the way, it's going to drive you crazy if you're monitoring that much. And getting jabbed by a needle that much is probably not a safe idea either, because it can introduce infection and stress and anxiety and waiting. So stop testing. Just wait for your ultrasound and see what your ultrasound shows, because there's absolutely nothing you're going to do that's going to make a difference. So all we do is we tell all our patients, don't test at home. Don't go buy 15 different pregnancy kits. Wait for your serum beta. If it's positive, you're pregnant, wait for your ultrasound. Sometimes we'll do another test to make sure it's rising. And then really only on the patients where they've had recurrent failures. But otherwise, you're just increasing your stress level, which actually just does damage. It doesn't help you.
Hi.
Hi.
I thought I had to read that way. There was an exclamation mark. I had to do what it's due. 26 years, been trying for 1 year and 8 months.
Okay.
3 early losses.
Oh.
I had laser surgery on a cervix in 2018.
That's not.
Could that be what's causing this?
No. So laser surgery to your cervix would be caused because of HPV infection, human papillomavirus infection for cervical dysplasia. And that has absolutely nothing to do with infertility unless your cervix is so tight, the sperm is not getting through. You're having losses, so you need a recurrent pregnancy loss workup. So you need to see a fertility specialist or a recurrent pregnancy loss specialist, which are by and large fertility specialists. And then we need to do a thorough evaluation and workup for you. If you've had 3 losses already in 18 months, there is almost certainly something wrong. Not necessarily something that we can't fix, but there's something going on there. So you should be investigated, and I would do that before you get pregnant again.
Is low BMI, example 17.5, an issue for conceiving?
Yes.
Even if you ovulate regularly on your own?
Yes, it makes it harder because you probably don't have enough body fat to have a thick enough lining in your uterus to support a pregnancy properly. So there are many studies that show that low BMI and high BMI are both problematic. Onto the poutine and avocado toast and all that fun stuff for you. Cheeseburgers, fries, cookie cake, ice cream, all stuff that got me to where I am right now.
Good. Sounds like a good weekend.
It was a really good holiday, yeah.
Why do home pregnancy tests show negative during the 2-week wait, but the beta can be positive? Why are home pregnancy tests unreliable? Well,
they're actually generally fairly reliable. They have anywhere from about a 93 to a 97% success rate, depending on which one you're using. Some of the ones that tout being able to detect early, like day 8 and stuff like that, if you read the fine print, and we have that video up now on our pregnancy tests, right? If you read the fine print, it tells you right there, it's only detecting it like a fraction of the time. It's not 90% or 97%. They're like 67% if you're trying to do it too early. Later, why can it be negative and positive? Well, if your beta is really low, it won't detect it because there is a threshold level that they detect. So even if you were positive and then miscarry or you're just a low positive because it's a chemical pregnancy or something like that, it could miss it. The other possibility is that they're bad kits. We get loads of people that don't want to spend the money to buy a Clear Blue Easy or a whatever brand that you want to buy, and instead they're going to the dollar store or buying them off of the internet, and God knows what you're getting there. So we don't necessarily recommend doing that, because I can't tell you what you're getting in those types of products. But keep in mind, it's like a chemical reaction on a stick. I mean, for all you know, it just wasn't set right at the factory. Whereas in a blood test, it's kind of hard for us to not have it correct, because we're running controls every time to make sure that we're getting the right answer when we run a blood test.
Hello, Dr. Victory. Currently 5 weeks pregnant after FET. I'm not feeling any symptoms though. I'm currently taking prolactin medication once weekly as well.
Yeah.
Could that be the reason?
If you're on high prolactin medication and you've got a positive pregnancy, you should be off of your prolactin medication. So if you're on bromocriptine or Dostinex, please stop. And no, I mean, every pregnancy is different. So some women have horrible symptoms right from the get-go. Other women are mild, moderate, and then some women have no symptoms whatsoever. So pregnancy does not come the same way for everybody. We get women that have no nausea or vomiting the entire time, and then we get women that can't stop vomiting throughout the entire pregnancy. Yeah.
Do you ever use letrozole in your IVF cycles?
Do I ever use letrozole in my IVF cycles? I'm not a big believer in the use of letrozole for patients trying their stim to improve the sort of ovarian reserve. So it has been tried for women with diminished ovarian reserve. There is no benefit to using letrozole over any other protocol or approach. And I have to say, in our hands, we've had lots of success with the microdose flare. So I have a patient working with another clinic overseas, actually, or was it in the US? In the US, whose physician would not listen to them. And was saying, we want you to do this type of approach. And I told her, you should really be doing the microdose flare. It'll work better for you. And she went from having no embryos the time before to having, I think she said, 5 genetically normal ones. So, it's a huge difference in outcome. Huge difference. So we use that all the time. That doesn't mean letrozole is not as good. I just don't use it because, what I'm using is working for us. I do, however, use letrozole every time when we're doing a frozen embryo transfer, because there it's been proven to be beneficial. So there's nothing wrong with using it in your protocols for your stim. I just haven't seen it be all that useful or better than what we're already doing. The only other time that you do need letrozole is if you're dealing with a breast cancer patient, because with breast cancer patients going through stim, you want to keep their estrogen levels low. And the way to do that is by putting them on letrozole as you're doing it.
TTC for 3 years, failed IVF, diminished ovarian reserve, and stage 3 endo.
Okay.
Conceived naturally, miscarried at 8 weeks.
Oh, so sorry.
Was planning IVF round 2 prior to spontaneous pregnancy. When should I start IVF?
Wow. Okay, so that's a great question. So first of all, I'm very sorry for your history, and thank you for being brave and sharing that with us. So I'm a big believer in dealing with your endo. So I would actually recommend that you, and this is based on what we've presented here. So if you have access to Vizan, if you're in Canada, take Vizan for 3 to 6 months first, then do your IVF cycle, then ideally do surgery. Do not do a fresh embryo transfer. Do your surgery, go on Lupron and letrozole for 3 to 6 months, and then do your embryo transfer. That is going to give you your very best chance of success. So that's what I would do. If you're asking just specifically time from this pregnancy to trying again, as I mentioned earlier, it doesn't make a difference. Just wait for a natural period and then you can start.
Just had a phone call with Dr. Mayran on the weekend.
Oh,
really awesome. Looking forward to starting this journey with you.
Awesome. Well, thank you. We love Dr. Mayran. She's amazing and a very, very valuable part of our team. She is frequently described as being made of kisses and rainbows. So Carrie's a wonderful human being in every way, and I'm really honored to have her as part of our team. She's amazing. She's just an absolutely amazing soul, and I love her dearly. So Carrie, if you're watching, I love you.
Hi, Dr. Vic.
Dr. Vic.
Dr. Vic.
Wow. Okay, go for it. Yeah.
That's what I got. I'm just reading them. I just
Yeah.
read them. I had a laparoscopy with you last week and just wanted to say thank you.
Oh, you're welcome.
I had no pain for recovery, and the incisions are so small and hardly noticeable. Thank you for your amazing work.
My pleasure, and I'm glad you recovered well and that everything went okay. If it was last week, it was my evil twin brother, though, because I wasn't in town last week. But I'm assuming you mean 2 weeks ago, and that is fantastic, and I'm glad you're recovering well. And everyone can feel free to call me Dr. Vic. I just haven't had that one before. We get called all sorts of things. Fire away. What's next?
Well, being in a caloric deficit, i.e. losing weight, impact TTC?
Positively, as long as you're not underweight. So let me rephrase that. Your caloric deficit and losing weight is beneficial if you're overweight. And that's been shown in a number of studies. I mean, I've lost track, right? So even a small percentage, 3 or 4% weight loss can significantly increase your success levels when you're trying to conceive. If you're underweight, like the earlier individual that was asking us, saying her BMI is now 17.5, yeah, that's not a good plan at all, because you're actually going to be underweight, and then you now are going to be struggling to get pregnant. So you want to be like a reasonable weight. For me, my kind of sweet spot for weight is a BMI of like 22 to 26. I don't need women to be too skinny, and I definitely don't want women to be overweight. And the guys are the same thing. So this is not female specific. Guys that are overweight have terrible sperm. Guys that are underweight are so rare, I don't talk about it that much, because it's very rare to meet a very slim guy. But the ones that we have had actually don't have great sperm either. So you want like healthy, right? And healthy is in that kind of sweet spot, 22 to 26.
Can I assume that 1 PN pronuclei, PGTA, day 5 embryo contains indeed DNA chromosomes of both mother and father? Any concerns with transferring this embryo?
So in the past, a pronuclear embryo that was you need 2 pronuclei, and if you had a 0 means it didn't fertilize. If you had a 1 or a 3 or even a 4, it was all considered abnormal. Because of the advent of PGT, they're now realizing that some of those are still normal embryos. So you can have a maternal and paternal contribution to an embryo that is genetically normal that does not have a normal number of pronuclei. So that's new. I read a study on that just a few months ago. So we don't focus on that as much anymore. Certainly if you have only a few embryos, and out of your few, you have most of them being abnormal numbers of pronuclei, that's an indication to do the PGTA for sure. I would strongly advocate for that in that situation. But if you have 1 pronuclear and a 3PN, and then you have 10 normal 2PN embryos, I mean, don't bother. It's not worth it.
Just to piggyback off of Lauren's question about caloric deficit, what about intermittent fasting and trying to conceive?
So I looked this up because we've been asked this several times, and there is absolutely 0 out there about intermittent fasting and trying to conceive. It's probably beneficial because we know that intermittent fasting is good for insulin metabolism, weight loss, all of those things. So I support it, but there's no evidence for it specifically in the fertility world yet. Great question. We just don't have an answer.
Okay. I was treated with cabergoline.
Cabergoline.
Cabergoline, of course. For a high prolactin.
Rubber baby buggy bumpers. Yeah.
The words that show up on here sometimes.
Okay.
So 3,305, and levels reduced to 296 in 2 weeks. But with the polycystic,
That was her prolactin level? It was
Yeah.
3,000?
3,000 reduced
Whoa.
to 296 in 2 weeks.
I've never heard of one that high.
But
Okay.
with polycystic ovaries,
Yeah.
did the high prolactin cause the PCOS? My
No.
testosterone and periods are normal.
No, a prolactin that high would have suppressed all of your LH and FSH from your brain. You wouldn't have had any impact on PCOS at all. In fact, if anything, it should have shut it down. So no, there's no association between those two at all. That's a really, really high. I mean, if it's the same units we use, that's a sky high level. You need an MRI of your brain to make sure you don't have a macroadenoma, which actually can sometimes require surgery. But I'm glad it's coming down so much because that's a step in the right direction. But in our units, your prolactin needs to be under 26, 28, 26. So depending on which lab you use. So you're still like 10 times over what we expect it to be.
Is there any changes or tips you'd recommend for taking injectables for plus size patients? This has always been a concern of mine throughout the IVF treatments.
Okay, so number one, we work really, really hard with our patients to not let them be plus size when we go through the IVF because it reduces your success rate. So we try very hard to work with you collaboratively to get you into the best shape you can be in before you begin your IVF. Once you're beginning the IVF, actually being plus size makes the injections easier because the injections just have to go into any kind of adipose tissue in your body, and then it gets distributed from there. You will need more if you weigh more and you have more adipose tissue. So the requirement of the medications is higher, but injecting it is easier because you have more sites to choose from. You just need more meds, which makes it more expensive and also is probably detrimental. So that's why we work with you to get the weight down. And my advice to everybody out there watching is if weight is a struggle, talk to us, find a sympathetic physician that wants to work with you and gives you the resources and the education and the support you need to help you get your weight down safely and securely and all that stuff, and helps you on your TTC journey. And we've got a great video on our YouTube channel that has that inflection point where your age and your weight start to reverse in terms of when it's better to continue with IVF. And that age is around 38, 39. So it's from a very large Chinese study, and they showed that after 38, 39, even if you had an elevated BMI, it was better to get into treatment because your age is becoming more of a factor than your weight is. But prior to 38, 39 age, if you're younger, you should lose the weight because your weight is more of a factor than anything else, and you're actually harming your success rates.
What do you do before a transfer? Does everything get checked, blood, ultrasounds?
So we have a really sophisticated protocol. We have loads and loads of steps to it. Aside from the mental health component, which is obviously critical, we have all the education and preparation. So we tend to start with Lupron, cycle day 21 of the preceding cycle. We wait for your natural period. We'll put you on letrozole and antibiotics. We'll put you on a probiotic. We have everyone on vitamin D and melatonin and prenatals, omega-3 fish oils, all sorts of supplements, depending on other things. Like if you have endo, there may be other protocols we involve as well. We make sure you're observing a healthy diet. And then we monitor your lining. We do not add estrogen in unless we have to. And then when your lining gets to around 9, 10 millimeters, 8, 9, 10 millimeters, we start you on progesterone. And we use progesterone in oil and we use vaginal progesterone. And we do monitor your levels. We then look for the amount of contractions in your uterus. We check for the compaction of the lining of the uterus to make sure the progesterone's working. And in certain circumstances, we use this matrix technology, which is the ultrasound scheme, which lets us see what our results are like. And then with that, we go from there and see how we're doing. So overall, for us, we're now in excess of 80% success per embryo transfer, and that's using single embryos. So we're doing a really good job.
What does the workup look like for a recurrent lost patient? I had my first appointment with you on the 20th. Really looking forward to getting some answers and help. Thank you for these Q&As.
You're welcome for the Q&As. I love doing them. Thank you for watching. So what does it look like? Well, part of it is a financial question, and we don't actually charge you anything. It's a financial question because some of the tests are not covered by OHIP, and they can be very expensive. So I'll go through what the possibilities are, and then I'll break down where the costs come up. So obviously your history, a physical exam, stuff like that is easy. Then we talk about your social habits. So do you smoke, drink, or use drugs, and your partner as well? In particular, the male partners, because if they're smoking, drinking, or using drugs, their sperm is terrible, and your risk of recurrent pregnancy loss is much, much higher. We look at your health in general, your body mass index, your weight, his weight. Then we look at the various factors that can contribute directly to it. So your genetics, his genetics, the chance of an infection in your uterus or your vagina that can be contributing, thrombophilia screen, which is blood clotting problems. We look at your hormones very carefully. We look at the shape of your uterus with a 3D ultrasound. And then there's a whole immune and of reproductive immunology, which can contribute to recurrent pregnancy loss as well. So the costs pop up when we start testing you for things like infections in your uterus, because we do that through Fertility, immunological testing, which is really expensive, and we do that through Fertility. And we only use them because they're the cheapest. So they're good, but they're, it's still pricey, but that's like half the price, probably even a third of the price of what it costs elsewhere. And then we have another one that is also available through other places that we can do as well for immunological testing. But again, I favor Fertility just because they're cheaper. And your thrombophilia screen will cost you as well, typically somewhere between $500 to $700. So there's the thrombophilia screen, there's going to be your immunological testing, and then there's the infectious testing in the uterus. Those are the three major items that are costly. Beyond that, if we can't find anything, there are treatments we apply. And then, of course, those treatments have costs to them sometimes as well. And that's just medication stuff. So yeah, I mean, that's where it comes from. And that's kind of the direction we take. We check everything first, figure it out, improve what we can, if we can, and then we move forward from there.
After a failed funded cycle with no embryos, what questions should I ask my clinic?
Ooh, you know what? I wouldn't ask your clinic. I would get a second opinion, because your clinic's never going to give you a full answer unless they're very, very honest, and that's rare. So we do. I mean, if someone gets nothing, I sit down and I tell them, what happened and why. If you were with us and you wanted to ask the right questions, my questions would be, was it an egg quality or a sperm quality? How long did you wait before you did whatever kind of IVF you were doing, if it was conventional or ICSI? And how long were the eggs sitting there before they were stripped and injected and so on, if you were using ICSI? I would want to know about other people in that same day or week or month to see how everybody else did as well, in terms of specifics. I would want to know if they had thoroughly tested you both before doing it. And then I would want to know about your stim. So I get patients all the time who tell me, I did a cycle, I got no results, no viable embryos, and I'm 47 years old. Well, that makes sense, because they shouldn't have started to begin with, because at 47 your chances are minimal. Or we get people that say, I stimmed for 16 days and none of my embryos were viable. Well, of course not, because you stimmed for 16 days. So sometimes, unfortunately, patients are not being canceled or told not to do IVF because of financial reasons, and that's ludicrous. So, if we start a cycle and it's not going in the right direction, I stop the cycle. I don't let people continue unless they have a very, very lengthy discussion with them where they understand that this is very suboptimal. Otherwise, we only do it when it's going to work. So I optimize everything. But those are the questions you want to know about, like what kind of stim did you have? What was the sperm quality like? What was the egg quality like? Who did the embryology? Where did the embryos go? What were other people's embryos like? How long did it take? All of those things are important. What kind of incubator did they use? There's some highly detailed embryological questions you can ask, but you either need my degree or a degree in embryology to be able to know all of that stuff. And I'm so sorry that you have to go through that. I will tell you, we have had loads of patients that have had no embryos develop in other centers, and then they've come to us and we've done perfectly fine for them.
I spot for some days before my period starts every month.
Yeah.
What causes this, and is this something I should be concerned about?
It could be fibroids or polyps, something structural in your uterus. It could be the shape of your uterus. It could be a hormonal issue. Rare circumstances, it could be infectious. So is it something to be concerned about? Not like in the sense of, oh my God, but yes, in the sense of it needs to be dealt with. So yeah, I would get checked out.
I'm 45 and my follicle count has been fluctuating between 2 and 9 since February. I had 4 on today's scan. How likely is it that I will get 8 or 9 again?
Wow. At 45, I would argue minimal. But if you're fluctuating, I guess there's a chance. I can't answer a question like that. It's impossible. You're asking me for what we call our crystal ball questions. We should get a crystal ball. You know what? We have to order a crystal ball. I'll pull it out and start checking it. You know what? It's a great question, but there's no way to know. I think the bigger and more important question for you is it worth waiting? And the answer is no, because at 45, even a few months is going to have a huge impact in your egg quality. So you should just be going ahead. Now, if you're talking about doing IVF, I would caution you to watch our embryo math video before you do that, because IVF at 45 is not very successful at all. And no matter what anybody tells you about how good they are or how great they are, it's just not realistic to expect a strong outcome at 45. That doesn't mean you shouldn't try. I'm 100% supportive of people that want to try. You just need to understand the math of what you're getting yourself into, because at 45, it will likely take you over 4 or 5 cycles of IVF to just achieve one live birth. So you're probably looking at somewhere between $60,000 to $100,000 worth of expenditure for you to get one baby out of it. And if that's worth it for you, great. But you need to have that discussion with your doctor.
Are there any genetic blood tests for a husband and wife to determine if they are compatible to have a baby or make it to the second trimester? Sperm is good, reoccurring miscarriage panel was good too.
There is. I mean, you need a karyotype if you haven't done that already. So that's the genetic test where you're looking for your chromosomal makeup and your partner's chromosomal makeup. But as long as that's okay, no, there's nothing else. Now, we do have patients that do the in vitae or fulgent testing with us, and we're looking for single gene defects, but single gene defects don't normally lead to recurrent pregnancy loss. Those are more chromosomal abnormalities.
Hi, Dr. Rahi.
Hello.
What are your usual protocols for couples with Y chromosome microdeletion? Did 2 failed IVFs, no embryo to freeze. We're both 34 years old. We were advised to look into sperm donors. Any advice?
So if he has sperm, he's got to have the AFZC gene deletion, because A and B, you have no sperm. C, you can have some sperm. So that should not be impacting your IVF. Now, it depends on what the quality of the sperm is like and the numbers and so on. But as long as they do ICSI for you, you should be okay. So that's puzzling. I would love to chat with you more. Why don't you reach out to me, DM me, and I will take that consult on my own. So reach out to us or just email info@drvictory.com, and I will happily set up a time to talk with you, because That doesn't make a ton of sense. You should be able to achieve embryos as long as there's sperm there, unless there's something else going on we're not aware of.
Do you keep your patients on baby aspirin for the entire pregnancy?
Yep. Next. That was an easy one. Yeah, that was a gimme.
My FET is 8/17. What kind of instructions do you give your patients right after the FET? Any restrictions?
My what is 8 out of 17?
My FET is 8/17.
8? Oh, August the 17th. Okay.
I
yeah.
guess so, yeah.
What kind of instructions do we give?
After FET, any restrictions?
No heavy lifting, no straining, no extremes of anything. So don't jump in a sauna or a hot tub. Don't try an ice bath. Yeah. Take it easy, meditate, pray, stay on all the vitamins and supplements. Do not go on Google. Do not go on Google. Do not go on Google. The number one thing you can do to fail in your attempt to succeed is go on Google, because everybody's looking up every twinge and finding some lunatic that still thinks that the vaccine is unsafe, and listening to what they say, thinking this is medical science, when in reality it's some lunatic that still thinks the vaccine is unsafe. So please stay off of Google. Google is wonderful if you know where to go in Google to find valuable and valid information. The overwhelming majority of people, including physicians, have no clue where to look or how to even analyze the data they see, which is why we do this show. So don't go on Google. Please, I beg you, stay off of Google. And for God's sakes, don't listen to, my Middle Eastern family either. I mean, in my family, my dad legitimately says that the day that I graduated, he got a medical degree as well. Everybody thinks they're a doctor in somebody's family. And so, don't listen to those people that say, oh, you need to do this and you need to do that, because none of them have a clue what they're talking about. Stay calm, stay positive, do whatever you need to do to stay calm and positive. Stay away from all the bad stuff, no drugs, no smoking, no alcohol, light exercise, be happy, pray, meditate, that kind of thing, acupuncture, just kind of general wellness stuff. That's what you need to succeed. Don't go on Google. Google is a disaster. Takes your stress level from here to infinity and beyond.
Yeah. Do AMH levels change while breastfeeding? If yes, how soon after stopping breastfeeding do you recommend checking AMH? Thanks.
I haven't looked that up before. It should go down though, because your high prolactin levels suppress everything. And we know that when you're suppressed, your AMH levels do come out lower. So I would expect that the answer to that question is yes. How long? Basically when your prolactin levels go down, that usually takes at least a couple of months, like 6 weeks, 2 months.
27 years old, third failed IUI on suspected male factor. Getting frustrated with our clinic, and we have an appointment with you, but not until November. Any further testing you do for males feeling lost?
We're booking into November? Wow. Okay. So we do a lot of testing on the males. So first of all, detailed history. We get rid of all the bad habits. So no smoking, no drinking, no drug use, loads of vitamins. So if you swing by our pharmacy, they can help you out. Just say, I need the male vitamins, and they'll tell you which ones are available. And then we do DNA fragmentation testing. And we have some really incredible avant-garde sperm testing techniques now, including an incubation overnight to see how many of the sperm are still swimming the next day. Because if less than 56% are swimming, your chance of success with IUI is less than 3%. So we don't do IUI for those patients until we've improved the sperm. So yeah, we do a lot of testing. There's a lot of elements to what we do. We go through your history in great detail. If your partner is smoking, drinking, using drugs, I'm going to tell you right now to get him off of it, because I will not do anything for you until he's stopped, because you're just wasting your time and money, and I don't believe in wasting anybody's time and money.
What vitamins should my partner male take before starting treatment? I feel like I'm a walking pharmacy over here, and he's just along for the ride.
Yeah, loads. So I don't promote any particular brand. We happen to use the products from Yad because they're Canadian and they're inexpensive. So I like that element. And Pro Fertile. So there's Fertile Pro, which is from Yad, and Pro Fertile, which is from Pro Fertile. And Pro Fertile actually has Health Canada approval for improving sperm quality, which is great. So they're both really good products. We have them both here, but it doesn't really matter what you use. You can even break it down into its individual components. You just need tons of antioxidants. So lots of vitamin support, lots of antioxidants. Stay away from everything bad. Keep your testicles cool. Ejaculate every 2 days. And keep cell phones and laptops away from your pelvis and groin.
For males, does smoking include vaping as well?
Yep. Vaping, horrible. You got to be crazy to vape. It's terrible for your lungs. It's got all sorts of chemical reactions going on in your lungs. Many, many people have died from those reactions. Stop smoking. Don't smoke marijuana. Don't smoke cigarettes. Don't vape. Don't use the hookah or the shisha or any of those things. They're all bad for you.
You answered that question without answering it. What vitamin and supplement would you recommend to improve? Egg quality.
Egg quality.
Yeah.
Supplements for egg quality?
Yeah, vitamins and supplements.
So coenzyme Q10, if you're PCO, inositol, and NAC, even if you're not, they're not harmful. Vitamin D, for sure, the fish oils. And then again, like a healthy diet, lots of antioxidants, C, D, E, for the vitamins. We use fertility vitamins sometimes. So Fertile Pro has Fertile Pro female, so that's really good. They have Inossia, which is their inositol. They have LQ, which is their coenzyme Q10. They've got all sorts of them. And then they have another one called Progestia. NFH has prenatal SAP. That's a great product. We have the video comparing the prenatals. There's Pregvite Folic 5, all sorts of different ones. So the keys are coenzyme Q10, inositol, NAC, curcumin is really good as well. The fish oils, those are all the important ones. Melatonin is good as well. So all of those can help you.
Hello to the best doctor.
Let's make this the last one then.
All right, here we go. Last question.
End on the best doctor one.
A couple of weeks ago, you mentioned the incubation for men's sperm. Is this done with a sperm analysis?
Yeah. So every time you give us a sperm sample to analyze, we do the initial analysis and then we keep it overnight. And then we analyze it again the next day, 24 hours later, to see how many of the sperm are still motile, because it is incredibly predictive of your success with an IUI. It's useless for IVF, but it's very predictive for IUI. We're done?
We got one more that just came.
One more, and then you stop? All right, one more. Tarek's terminal question.
No, it's not a terminal question.
Okay.
But it's a question for sure. I'm plant-based. I'm taking a plant-based omega-3 supplement. Will that work the same as a fish oil? If not, I'm open to taking fish oil in order to help.
That's a great question. You can get your omega. Okay, that's a Jen Strong question, but there are non-fish sources of omega-369. So yeah, I think you can still get that in your plant-based diet. There's no reason why you can't. So that's not a problem. But Jen Strong, if you're watching, can you put up a post somewhere answering that question for this lovely individual? Okay, and with that, Tarek and I are starving to death because we didn't get to eat before the show. So I love you all. Thank you for welcoming us back into your lives. Sorry we were away for a week, but we're back. And next week, make sure you watch, bring your friends, bring some popcorn. I'll wow you with the information that's out because it is really important for bucket loads of people who have not been getting the right treatment. So come and watch that show. All right, guys, have a great night. Stay safe and get vaccinated. Get vaccinated. Get vaccinated. Take care. Bye now.